Hello friends, welcome to today's lecture on question banks. We'll do question banks from UWorld. So let's start. Now in this question, a 36-year-old woman comes to the office after she noticed some lumps under her arm while getting dressed. She says she feels fine and has no other symptoms. Her medical history is significant for hypothyroidism. Family history is negative. On physical examination, her body mass index is 24 kg per meter square. Breast examination shows non-tender left axillary lymph adenopathy. The patient is sent for an ultrasound guided biopsy. Microscopy of the tissue specimen shows clumps of cells that have positive immunohistochemical staining for cytokeratin. These cells most likely belong to which of the following lineages? Since the immunohistochemical staining is positive for cytokeratin, it is derived from epithelial lineage. Cytokeratins are proteins that help form the keratin containing intermediate filaments that make up the cytoskeleton of almost all epithelial cells. Keratin proteins are highly abundant in exposed stratified squamous epithelium such as the epidermis and oral mucosa, and are less abundant but still present in simple epithelium such as that found in the liver, gut and pancreas. As a result, cytokeratin is a commonly used immunohistochemical marker for epithelial-derived tumors such as breast cancer. Keratin is also the major protein component of hair and nails. Keratin is composed of large amounts of alanine and glycine that, because of their small structure, are able to coil tightly and form large numbers of hydrogen bonds. In addition, keratin contains a significant amount of the sulfur-containing amino acid that is cysteine, and formation of disulfide bonds between cysteine residues give additional rigidity and toughness to this protein. Other options were incorrect, as in choice B. CD20 is a marker which is used to identify B lymphocytes and CD3 is used to identify T lymphocytes. Since they were not the mentioned markers over there, hence it was not appropriate. In choice C, vimentin is an intermediate filament present in mesenchymal tissue and can be used to detect sarcomas. In choice D, myeloperoxidase is a peroxidase enzyme that can be used as a marker for myeloid cells such as those in acute myeloid leukemia. In choice C, chromogranin A and synaptophysin are markers for neuroendocrine tumors. Since such markers were not mentioned in the question, thus these answers were inappropriate. In summary, cytokeratin is a commonly used immunohistochemical marker for epithelial cell carcinomas. Now the question is continued, and in this the cells identified by the spatial immunohistochemical stain are shown to overexpress a 185 kD glycoprotein that spins the cell membrane and has tyrosine kinase activity in the intracellular domain. So which of the following is the most likely function of this protein? Earlier, from the first part of this question, we get to know that the patient is actually suffering from breast cancer. And now in this question, it is saying that the cells are having the tyrosine kinase activity in the intracellular domain. This actually indicates the expression of the HER2 gene, which is responsible for encoding epidermal growth factor receptor with tyrosine kinase activity in the intracellular domain. The HER2 gene mutation is actually responsible for breast cancers, and this HER2 gene leads to the or plays a role in cell proliferation and growth. Thus, the answer is A. It accelerates cell proliferation. The HR2 oncogene codes for a human epidermal growth factor receptor with tyrosine kinase activity in the intracellular domain. It is known to play a role in the activation of transduction pathways that control epithelial growth and differentiation. Epithelial cell carcinomas that overexpress HER2 demonstrate increased proliferation and resistance to apoptosis. Consequently, HER2 positive breast cancers have a higher risk of disease recurrence and worse prognosis compared to HER2 negative breast cancers. Trastuzumab, a monoclonal antibody against HER2, is used to treat women who test positive for overexpression of the HER2 oncogene. The other options were incorrect, as in choice B. Estrogen and progesterone receptors are intracellular receptors that are frequently overexpressed in patients with breast cancers. Stimulation of these hormone receptors increases cellular proliferation, and patients with hormone receptor positive breast cancer are treated with anti-estrogen medications to suppress tumor growth. In choice C, intracellular binding is mediated by cell surface proteins such as intracellular adhesion molecules, also known as ICAMs, selectins, and numerous others. Many adhesion proteins, including ICAMs, also play a role in signal transduction. In choice D, various hormones, cytokines, and other stimuli can induce cytokine release from a number of cell types. One example of a receptor that induces cytokine release is the toll-like receptor, which detects conserved microbial molecular structures. In choice E, clathrin is an intracellular protein that helps form rounded vesicles in the cytoplasm. Clathrin-coated vesicles help mediate intercellular trafficking and endocytosis. In summary, the HER2 oncogene encodes for a transmembrane glycoprotein with intrinsic tyrosine kinase activity and is a member of the family of epidermal growth factor receptors. Overexpression of this protein is associated with a worse prognosis and increased risk of disease recurrence. Now moving on with next question. Certain patients with non-small cell lung cancer develop constitutive tumor kinase activity due to production of echinoderm microtubule associated protein like 4 anaplastic lymphoma kinase, that is EML4 ALK, a fusion protein that contributes to carcinogenesis. This is most similar to the molecular pathophysiology of which of the following disorders? So it is most similar to pathophysiology of chronic myelogenous leukemia, where there is also the formation of fusion protein BCR-ABL. Thus, the answer to this question is B. Now, this slide demonstrates the formation of the AML4 ALK fusion protein in non-small cell lung cancer. Approximately 4% of patients with non-small cell lung carcinoma have an inversion of the short arm of chromosome 2 that creates a fusion gene between EML4 and ALK. This results in a constitutively active tyrosine kinase that causes malignancy. Interestingly, patients who harbor this gene fusion are usually young non-smokers, often with adenocarcinoma, who lack mutations in either the epidermal growth factor receptor gene or the KRAS gene. The kinase activity of this fusion protein is a target of the protein kinase inhibitor like crizotinib. The pathophysiology of EML4-ALK NSCLC is most similar to the pathophysiology of chronic myelogenous leukemia. In CML, the classic and most common cause is a translocation between chromosomes 9 and 22. The ABL proto-oncogene is transported from chromosome 9 to chromosome 22, where it is placed adjacent to the BCR gene. The resulting oncogene BCR-ABL codes for a fusion protein with constitutive tyrosine kinase activity. This protein stimulates the proliferation of granulocytic precursors and leads to the development of CML. The kinase activity of this fusion protein is a target of the protein kinase inhibitors like imatinib. Now, other options were incorrect, as in choice A. Burkitt lymphoma is characterized by translocation of the c-Myc oncogene onto the long arm of chromosome 8 to the Ig heavy chain region on chromosome 14. This causes constitutive overproduction of c-Myc, a nuclear phosphoprotein that functions as a transcription activator. In choice C, patients with follicular lymphoma have a T1418 translocation that causes overexpression of the anti-apoptotic BCL2 gene product. In choice D, Lee-Fraumeni syndrome is an autosomal dominant predisposition to a variety of cancers, particularly sarcomas and tumors of the breast, brain, and adrenal cortex. This syndrome is associated with mutation of the tumor suppressor gene, that is P53. In choice C, translocation between the cyclin D1 locus on chromosome 11 and the IgG heavy chain locus on chromosome 14 is characteristic of mantle cell lymphoma. This abnormality results in increased production of cyclin D1, which is a promoter of the G1 to S phase transition during the cell cycle. In summary, some patients with non-small cell lung carcinoma harbor a chromosomal rearrangement that creates a fusion gene between EML4 and ALK. This results in a constitutive active tyrosine kinase that causes malignancy. In this question, a 28-year-old woman comes to the physician after finding a lump in her right breast. Her mother died from ovarian cancer at age 34 and her aunt died from breast cancer at age 32. After the appropriate workup, she is diagnosed with breast cancer. This patient most likely inherited a mutation in a gene normally responsible for which of the following processes? Now, the most important key finding to be noted in this question is inherited mutation in a gene. So it is a inherited gene mutation which has led to the breast cancer in this patient. Now, most cases of hereditary breast and ovarian cancers are associated with mutations in the tumor suppressor gene, basically BRCA1 or 2. These tumor suppressor genes are involved in DNA repair. Hence, the answer to this question is B. The majority of breast cancer cases occur sporadically in women age of greater than 50. Hereditary breast cancer should be suspected in patients diagnosed at a young age. Patients with 2 or more primary breast and or ovarian cancers and individuals with multiple family members affected by early onset breast or ovarian cancer. Most cases of hereditary breast and ovarian cancer are associated with mutations in the tumor suppressor genes as BRCA1 and BRCA2. These tumor suppressor genes are involved in multiple processes including DNA repair, cellular differentiation, checkpoint control of the cell cycle, and also the transcription factor regulation. BRCA1 and BRCA2 in particular are involved in repair of double-stranded DNA breaks. Mutations in BRCA1 and BRCA2 result in genetic instability, predisposing cells to an increased risk of malignant transformation. Both BRCA mutations are inherited in an autosomal dominant manner with variable penetrance. Affected women have a 70 to 80% lifetime risk for developing breast cancer. Moreover, their lifetime risk of developing ovarian cancer is also increased by up to 40%, although the BRCA2 gene is less likely to lead to a ovarian cancer. Other options were incorrect as in choice A. Angiogenesis is an essential factor in the growth of tumors due to their rapid rate of division and high metabolic demands. Although they stimulate angiogenesis by increasing production of substances such as vascular endothelial growth factor, these tumors frequently outgrow their blood supply and become necrotic in the center. In choice C, intercellular adhesion is impaired in the majority of malignant tumors, which allows portions of the tumor to break off and undergo metastasis. Adhesion molecules such as E-cadherin are also responsible for transduction of growth signals important for normal tissue growth and regeneration. Disruption of intercellular adhesion signaling can promote unchecked cellular proliferation. And choice D, protein degradation is essential for regulation of cellular functions and is performed by the proteasome as well as cytosolic protein immunogenesis, increased degradation of protective proteins such as PE53, or decreased product breakdown of proteins that favor cell division can lead to malignancy. In choice C, a large number of malignancies are associated with aberrant signal transduction. For example, overexpression of HER2, a receptor tyrosine kinase involved in growth signal transduction, causes the development of certain types of aggressive breast cancer. But unlike BRCA1 and BRCA2, HER2 mutations are acquired and they are not inherited. Please do remember this. Since they were acquired and they are not inherited, hence this was not the appropriate answer. In all, summary is that the hereditary breast cancer is most commonly associated with mutations in BRCA1 and BRCA2. The tumor suppressor genes are involved in DNA repair, and their mutation increases the risk of developing breast and ovarian cancer. Now, in this question, a 26-year-old woman is being treated for glomerulonephritis, photosensitive skin rash, and arthralgias. Rapid plasma reagent test is repeatedly positive in this patient despite negative treponema pallidum. Enzyme immunoassay testing. Coagulation study results are as follows: bleeding time normal, activated partial thromboplastin time prolonged, prothrombin time normal, platelets normal. This patient is at greatest risk for which of the following complications? The patient's symptoms of glomerulonephritis, photosensitive skin rash, and arthralgias is suggestive for SLE, and this conclusion is actually also supported by positive RPR test and also prolonged activated partial thromboplastin time. Now, the SLE can lead to complications such as recurrent miscarriages. Thus, the answer to this question is D. Glomerulonephritis, a photosensitive skin rash, and arthralgia in a young woman are all suggestive of SLE or systemic lupus erythematosus. This patient's prolonged activated partial thromboplastin time, or APTT, and false positive rapid plasma reagent test further suggests the presence of circulating anti-phospholipid antibodies. Although anti-phospholipid antibodies cause APTT prolongation in vitro, they act in vivo to produce a hypercoagulable state due to activation of phospholipid-dependent coagulation pathways. These antibodies can also cause false positive results on non-treponemal serologic syphilis test, example RPR and VDRL, by reacting with cardiolipin, the dominant antigen used in these tests. Antiphospholipid antibody syndrome is a disorder characterized by the presence of antiphospholipid antibodies in the setting of venous or arterial thromboembolism and or recurrent pregnancy loss. APS may be a primary disorder or occur secondary to other autoimmune diseases such as SLE. Although antiphospholipid antibodies are present in 10 to 30% of patients with SLE, not all exhibit the clinical syndrome. Other choices were incorrect, as in choices A and E. SLE is less likely than other connective tissue diseases such as scleroderma or mixed connective tissue disease to involve the esophagus. Sclerodactyly is also more typical of the CREST syndrome or scleroderma. In choices B and C, painful hemarthrosis and or menorrhagia would be indicative of hypocoagulable state. Although antiphospholipid antibodies can prolong the APTT and sometimes prothrombin time, patients with APS experience thromboembolic events, not increased bleeding. In choice F, TAPes dorsalis is a manifestation of tertiary syphilis that results in sensory ataxia. The inability to confirm syphilis screening tests with more specific treponemal tests such as treponema pallidum, enzyme immunoassay or TPEIA or fluorescent treponema antibody absorption test, or FTA-ABS, argues against the diagnosis of syphilis, and hence it was not the appropriate answer. In summary, glomerulonephritis, a photosensitive skin rash and arthralgias in a young woman are suggestive of SLE. Up to 30% of patients with SLE have antiphospholipid antibodies, which can cause paradoxical APTT prolongation and a false positive RPR or VDRL. Patients with antiphospholipid antibodies are at risk for venous and arterial thromboembolism and unexplained recurrent pregnancy loss. Now, this slide demonstrates the antiphospholipid antibody syndrome, where the clinical features include venous or arterial thromboembolic diseases, deep venous thrombosis, pulmonary embolism, and ischemic stroke or transient ischemic attack. Also, it could lead to adverse pregnancy outcomes as unexplained embryonic or fetal loss, premature birth due to placental insufficiency, or preeclampsia. Lab findings suggest of lupus anticoagulant effect as paradoxical APTT prolongation not reversed on plasma mixing studies, and presence of specific antiphospholipid antibodies, that are anticardiolipin antibody and anti-beta-2 glycoprotein 1 antibody. In this question, a 35-year-old man comes to the physician with a skin rash. He was treated in the hospital for pneumocystic pneumonia and painful oral ulcers 6 months ago. He currently takes no medications but drinks alcohol frequently and uses illicit drugs. Physical examination shows a widespread rash consisting of lesions similar to that shown in the image below. So, which of the following is the most likely cause of this patient's current condition? So, the clinical history of pneumocystic pneumonia and the painful oral ulcers, especially in illicit drug user, is highly suggestive of HIV infection. And the most common tumor in HIV positive individuals is Kaposi sarcoma, that presents with a multiple blue, violet, or brownish dermal plaque that appears on legs and feet, which was presented in the picture before also in this question, and thus the answer to this question will be human herpes virus type 8, that is HHV8, that is commonly or strongly associated with Kaposi sarcoma as of with HIV. The clinical history of pneumocystic pneumonia and painful oral ulcers in an illicit drug user is highly suggestive of HIV infection, and diagnosis further supported by the presence of Kaposi sarcoma. The most common tumor in HIV positive individuals is Kaposi sarcoma, which presents as multiple blue, violet, or brownish dermal plaques that appear and that first appear on the feet and legs before spreading proximally. Kaposi sarcoma lesions can also develop on the mucosal membranes of the face and genitals. In patients with late stage disease, the lesions spread to the lungs and GIT. Histologic examination of skin afflicted with Kaposi sarcoma shows spindle and endothelial cell proliferation, red blood cell extravasation, and inflammation. KS is strongly associated with both HIV and the human herpes virus type 8. HHV8 DNA has been isolated in the neoplastic cells of KS. HHV8 infects vascular and lymphatic endothelial cells, causing their differentiation into a mixed phenotype that is thought to increase oncogenic potential. The HHV8 genome also contains several viral oncogenes that inhibit both cell cycle regulation and apoptosis, thus promoting tumorigenesis. Other options were incorrect, as in choice B. Cytomegalovirus infection in HIV patients typically cause esophagitis, colitis, and retinitis. CMV can also cause a mononucleosis-like illness with rash, but the rash usually has a maculopapular or morbilliform appearance and not the blue-violet appearance and hence it was not appropriate. And choice C, like HHV8, Epstein-Barr virus also belongs to herpes viridae family. Epstein-Barr virus causes infectious mononucleosis and is associated with Burkitt lymphoma, nasopharyngeal carcinoma, and central nervous system lymphoma in HIV-positive patients. Hence, it was not appropriate. And choice D, chronic infection in hepatitis C virus increases the risk of developing hepatocellular carcinoma. Since it was not such mention, it was inappropriate. Human in choice G, human papilloma virus strains 16, 18, 31 and 33 are associated with squamous cell carcinoma of the cervix and vulva and therefore it was inappropriate. In choice H, human T cell leukemia virus type 1 belongs to retroviridae. It causes T cell leukemia, especially in patients originating from southern Japan, and hence it was inappropriate. So this slide presents to you the histologic examination of skin affected with Kaposi sarcoma showing spindle and endothelial cell proliferation with red blood cell extravasation and inflammation. Now in this question, a 7-year-old boy is brought to the office due to fatigue, easy bruising and frequent epistaxis for 2 weeks. He has no problems and takes no medication. His temperature is 36.7 degrees Celsius. Blood pressure is 90 by 60 mmHg. Pulse is 94 per minute. Respirations are 18 per minute. Physical examination reveals pallor and multiple ecchymosis. There is no lymphadenopathy or hepatosplenomegaly. Lab results are as follows, indicating hemoglobin to be low, platelets are low, leukocytes are also low. A bone marrow biopsy is shown in the image below. Which of the following is the most likely diagnosis? In the biopsy, we can see that there is highly replacement of the bone marrow cells by the adipose tissues and therefore it is indicating that the bone marrow has become hypocellular. So the bone marrow biopsy and the patient's lab results indicating pancytopenia is most indicative for idiopathic aplastic anemia. So the answer is C. Aplastic anemia is defined by pancytopenia with bone marrow hypocellularity. Most cases of AA are acquired from a direct toxic insult or T cell response leading to apoptosis of pluripotent stem cells. The etiology is unknown in most children, but the damage may result from drug exposures like chemotherapy, benzene, carbamazepine, and some viral infections as hepatitis and Epstein-Barr virus. It presents with progressive signs and symptoms of pancytopenia, such as bleeding from thrombocytopenia, pallor and fatigue from anemia, and bacterial infections from leukopenia or neutropenia. Splenomegaly is notably absent due to lack of available hematopoietic progenitor cells and therefore a lack of extramedullary hematopoiesis. Other options were incorrect, as in choice A, acute lymphoblastic leukemia is the most common childhood malignancy, but it presents with lymphadenopathy and hepatosplenomegaly, which was absent in this case and hence was inappropriate. Also, the bone marrow aspirate reveals hypercellularity and lymphoblasts in such case, but in this the bone marrow biopsy reveals hypocellularity and hence the choice A was not the correct answer. In choice B, Fanconic anemia is an inherited cause of AA that presents with short stature and absent thumbs with an increased risk of malignancies like myelodysplastic syndrome and acute myeloid leukemia. Since there was not such mention of short stature and absent thumbs, this was also not the correct answer. In choice D, myelodysplastic syndrome is caused by defect in stem cell maturation leading to ineffective differentiation of cell lines and therefore pancytopenia. But the bone marrow biopsy here will indicate hypercellular cells or hypercellularity with abnormally differentiated cells, that is mishapen nuclei. MDS primarily occurs in patients age of greater than 65 and not in younger persons. In choice C, parvovirus B19 infects erythrocyte precursors and can cause aplastic crisis for red cell aplasia only. In patients with pre-existing hematologic diseases, example sickle cell anemia or hereditary spherocytosis, leukopenia and thrombocytopenia can also be found in immunocompromised patients. So, the pathogenesis of the aplastic anemia is the bone marrow failure due to hematopoietic stem cell deficiency. The causes is autoimmune infections, drugs, and exposure to radiation or toxins. The clinical and lab findings include anemia, thrombocytopenia, and leukopenia, and the biopsy reveals hypocellular bone marrow with fat and stromal cells. This is all for today. Thanks for watching. If you like this video, please do subscribe and share.